In this lecture, we will discuss ventricular escape beat, including its origin, mechanism, EKG features, and potential causes. Generally speaking, ventricular escape beats result when the sinus node, AV node, or any other supraventricular pacemaker cells fail to fire. Consequently, automatic pacemaker cells within the ventricle must take over or escape from their usual control by higher pacemaker sites in order to maintain the heartbeat. So as you may expect, we can see this in beats, these sort of beats in patients with sick sinus syndrome or sinus node dysfunction or AV block with inadequate escape rhythm, among many other causes. So if you look here, notice that we have our sinus node up here, okay? This is our AV node, all right? And then we have here our ventricular escape beat coming from our left ventricle, okay? And what we're saying here is that all these pacemakers above our ventricles are not firing. So one of them within the ventricles ends up escaping, okay, in order to maintain that heartbeat, okay, because those above it are not firing. In doing so, it fires at this pace, okay. So what can we see on the EKG? Well, in general, if you look at the EKG and you see a beat that occurs later than you expect for the underlying rhythm, has no identifiable P waves, and has wide, bizarre appearing QRS complexes, different from those of the normal sinus beats, then you're likely dealing with a ventricular escape beat. The QRS interval is prolonged because intraventricular conduction is occurring outside the normal conduction system via cell-to-cell depolarization, which is a slower process and prolongs ventricular depolarization. So again, we're firing at a place outside our normal conduction system, so right here, okay? So everything came down, nothing was firing, and we came to our ventricles, and what happens is, because it's coming from our ventricles, we're going to have this slow cell-to-cell depolarization, which is much slower than our normal conduction pathway, right? Think of it as our highway, so we're outside that normal highway pathway, so things are going to go slower, and because we're in the ventricles, we're going to see that wide complex, so our QRS complex will be prolonged, okay? So we have a prolonged QRS complex greater than 110 milliseconds. Remember, it's about 3 small boxes. Now, one thing to note is that it's possible to have retrograde capture of the atria, in which we may see P waves with abnormal axis occurring after the QRS complex. Now, this is less often seen, but it's still possible. Remember, I said that you don't see the P waves, okay, oftentimes, because it's coming from the ventricles, all right, and you often don't have that retrograde conduction. So what do I mean by that? Well, from this area that is setting off and acting as our pacemaker, we often don't have retrograde conduction, or at least see it on the EKG, but you may sometimes see it as a retrograde P wave as it comes back and depolarizes the atria, okay? So we may see an actual P wave after our QRS complex within, buried maybe within our ST segment and T wave, or towards the end of our QRS. All right, you can see a retrograde P wave. Again, not always present. Okay, so another thing to be aware of is that there will be a non-compensatory pause following the ventricular escape beat. So what do we mean by this? We mean that the beat following the ventricular escape beat will occur on a new timing cycle, and possibly at a different rate than the once underlying pacemaker that was set. In other words, the underlying rhythm does not compensate for the ventricular escape beat, as you may see with premature ventricular contraction, but instead affects the overall timing of the beats that follow. So what we will see here is that the next normal beat following the ventricular escape beat does not occur at the interval that is equal to 2 times the preceding R to R interval. Okay, so now we're talking about our this is a non-compensatory pause, okay, and we see that here. Remember, our normal R to R intervals from one R wave to the next. We have that here, okay, and what we're saying is here is where our next R wave should fall, all right, but it's not firing, so eventually our ventricular escape beat occurs, wide, no P waves, okay. And then afterwards, if we were to continue on this normal R to R cycle, the next R wave should occur here, okay? And if it was compensating for this ventricular escape beat, this is where the R wave would occur. Instead, it's occurring at this point, okay? And that's what we call a non-compensatory pause, where the overall timing of the rhythm is actually affected. So hopefully that's not too difficult. Let's quickly run through our chart here before we end. So ventricular escape beat results when the supraventricular pacemaker cells fail to fire. Okay, so they're not firing from above it, and because of that, the impulse is originating from within the ventricle. And because of that, we get these late, okay, not, remember, premature, we're coming early, these are coming late, they're wide and bizarre appearing QRS complexes as we saw here. Oftentimes we don't see the P waves within them. Some causes are sinus node dysfunction, okay, the sinus node not working, AV blocks, so something here in the AV node blocking the impulse from getting through, and then also having an inadequate junctional escape rhythm, meaning the rhythm is not, there's not enough rhythm coming from that junctional area in the setting of an AV block. Okay, there's many other causes, but those are just a few. Now we said there's a non-compensatory pause where the overall timing of the beat or of this rhythm is affected. This is an irregular rhythm, right? Should make sense. Our R to R intervals are not consistent throughout because of this ventricular escape beat throwing all the timing off. We said the rate depends on the underlying rhythm. The P waves are often not present, okay? And because the P waves aren't present, the P to QRS ratio is, we often don't have one, okay? Because there's no P wave. Similarly for the PR interval, if there's no P wave, we have no PR interval. Now if there's a retrograde P wave, because of that retrograde atrial conduction, we could see a retrograde P wave, and in that case you would have a 1-to-1 ratio, and you would also have a short or retrograde PR interval. The QRS interval will be prolonged, okay? Remember, we're coming from our ventricles. This is a impulse that's originating in the ventricles. Because of that, we have a slow cell-to-cell depolarization, and everything will be prolonged, okay? So prolonged QRS interval greater than those 3 small boxes, or at least 3 small boxes, and abnormal QRS morphology, okay? Different from our underlying QRS complexes. There's often no grouping, and there are no drop beats. Well, that's the end of this lecture. We discussed ventricular escape beat, including its origin, mechanism, EKG features, and potential causes. I hope you learned something.